Thanks for having me. I think I've definitely met a lot of you before. I've had a lot of patients here, so I've come to visit, so a lot of familiar faces. So what I wanted to talk about today was hip arthritis, what you do for it, because it is so common, and specifically a type of hip replacement that we offer at Morristown Hospital, and that's the anterior approach to the hip for hip replacement. Who's heard of that procedure here, specifically the anterior approach? All right. Before we get in, it'd be fun. Who said that they heard of it? Gentlemen there. What are some of the advantages you've heard of the anterior hip being?
Just that it's a different approach than when they do the surgery. They go from the front.
Okay. Well, that's absolutely correct.
That's the of this location.
Very good. Very good.
They're ambulatory and standing up pretty much after surgery.
Yeah. So those are the big things. Those are the big three. So it's a different approach. Less chance of dislocation. Because of that, there's no precautions, and we'll go through it. And again, you'll see that there's no disruption of muscles or tendons, so people are up quicker and recovering faster. So we're from Morristown Hospital. I know you're all very familiar with it. A lot of patients come here from there. It's over 700 beds. It's a level 1 trauma center. We have very good nursing staff, and I get accredited. And it's a center of excellence for total joint replacement. That's accredited by the American College of Surgeons. So we're very proud of that. Okay, so what we'll go over today is we'll do an overview of what hip arthritis is, symptoms, the treatment options. We'll go through least invasive to most invasive, and then we'll talk specifically about what's special about the anterior approach. So what is arthritis? Normally, the hip, just like any joint, is lined with cartilage. It's two bone ends that have this smooth cartilage on the end, and when it's wet, your body makes natural joint fluid, and when those surfaces get wet, it's very slippery. It's less friction than wet pieces of ice on themselves, so they glide. That's why people normally have smooth, painless motion. Everyone can see? And here, because we're talking about the hip, here's a shot of the hip, and you can see that they're matching shapes. You have a ball that fits into the socket, and you have cartilage on cartilage, so very smooth. On X-ray, that cartilage, you can't see cartilage on X-ray because it's mostly water. Instead, what you see is the space that exists between the ball and socket, and that represents cartilage. So in nice, healthy hips, you'll have this nice arc of cartilage. With arthritis, there's something wrong with the cartilage. There's many causes of arthritis. It can be inflammatory, like rheumatoid arthritis. You can get the more common wear and tear, osteoarthritis. People who have had previous traumas through the joint can get arthritis. And so basically what it is just a disease of the cartilage. The cartilage wears and you have less covering on the bone. And it's no longer smooth and painless, but it's more broken down. The cartilage is gone, so that's why you have stiffness, grinding, and pain. And you can even see the difference on the X-ray. No longer is there this nice halo of cartilage. Instead, the joint space is obliterated. It's gotten so bad that you see the ball is no longer a ball, but it's actually flat. You see the bone is all white. That's sclerotic. It's a reaction to grinding, inflammation, wear and tear. So what can you do for arthritis? Well, in the early stages where the cartilage just starts to wear and you start to have the beginning of joint pain, you can do things like modify your activity. The things that make it hurt, you don't do it as much. So if running makes it hurt, you stop running. Lifting heavy objects, certain sporting activities. When it gets a little worse, you may have to modify even more by using a walker and a cane. Now, a lot of people will argue, and I will argue, that's not really an acceptable option, right? You want to stay healthy, you want to remain active, so you don't want to walk around with a cane. You want to get back to your activities and maintain your health. So what can you do? You can take medications.
I like that.
You like that? You can take happy pills. These a lot of things that aren't really proven in the literature yet, but are sold in drugstores that do work. I have a lot of anecdotal patients who have told me that they take glucosamine and chondroitin sulfate and they've had relief from it. You can take non-steroidal anti-inflammatories, so anything over the counter like naproxen, Aleve, Advil. If you have stomach issues, you can get prescription for Celebrex. It's easier on the stomach. And what these tend to try to do is calm down the inflammation that's going to sort of reverse the process going on in the joint. Other thing is physical therapy. By strengthening the muscles that cross the joint, you can reduce the reaction forces in the joint so you have less pain. You can do injections. Cortisone can help calm things down, or high hyaluronic acid supplements like Synvisc. The thing is, though, when you reach a certain point and you're bone on bone, these things aren't really going to help. If you have no cartilage to treat, then things like injections, therapy is just not going to work. Okay, so the definitive treatment is to take the joint out, right? There's nothing to work with anymore. The cartilage is completely gone. You're going on bone. The only relief you're going to get is to put in a new joint, so a hip replacement. And a hip replacement is exactly that. We take out the diseased head and neck, the ball, and we replace it with a stem down the femur with a new mechanical ball. And then the socket is also prepared. We take away any remaining unhealthy bone and put in a mechanical socket. You see the pieces are modular. The more common implants we use is either a ceramic or a metal head, and then what we call a plastic liner, but it's really polyethylene. It's just a highly polymerized type of plastic. And this, when wet, sort of imitates your natural cartilage. It's very slippery. So the traditional approach is the posterior approach, or through the back. Okay, people are lying on their side. There's an incision. You've probably all seen it. There's an incision down the side, and we have to split the gluteus maximus muscle. Right, that's the big muscle that's going to be lying over where we need to approach. We literally split it in half, and then we're looking at all these muscles here, which are called the external rotators. They come off of the pelvis and they attach to the back of the femur or the trochanter here. We have to cut all of them. So we're splitting the glute. And then we cut all these muscles off here and flip it. And when you flip them back, then you're looking at the back of the hip, the femoral neck, and the back of the socket. And that's how we get in and out. Now, it's a very easy approach to do. It's very quick, but the problem is when you're done, you've now disrupted the posterior restraint of the hip. We try to plug them back into the bone with sutures through holes, but it's never as strong as your natural hip. And you can pull out at any time. And actually, some people have done studies. Where I did my residency, they did a study. They put clips on each side of the repair, and then with time, they would take X-rays and they showed that the clips moved away. So that repair didn't even last anyway. So and because of that, you have precautions. You can't flex your hip past 90 degrees. You can't internally rotate past neutral. Yes, sir.
Does that contribute to the current trend in higher failure rates in the total hips? Is that one of the reasons why you switched to the anterior approach?
No, well, I switched to anterior because that's how I trained.
Okay.
And when I first went to Morristown, I started doing posterior approaches, but we needed a special. You need a special table to do this correctly, and the most effective way is with a special table. And only within the last year and a half did we get that table, so we were able to switch. But the high failure rates are from metal on metal bearings, which we don't use.
Okay.
And this is some of the implants from certain companies that have recalls because they're worn quickly. So getting back, so the precautions is you can't flex past 90 degrees, so you can't squat, can't sit in a wheelchair, can't rotate internally past neutral, can't cross your legs. The other big thing is you have to wear an abduction wedge, for the first couple of months or so while you're in bed, and also sometimes while you're sitting. And the reason we have these precautions is because the ball is most likely to pop out the back. And it's these motions that push the ball out the back of the socket. So all these things you're not allowed to do after hip replacement. And theoretically, these are lifelong precautions. No crossing the legs, no sitting in low seats, so you have a special chair for your toilet, and definitely no squatting. And you guys all seen the wedges. That's probably the most bothersome thing. When I used to do posterior approaches, people were like, "When can I get rid of this pillow?" Because it's really a pain in the butt. You have to sleep on your back, and not a lot of people are used to doing that. The other downside to the posterior approach is the patient is positioned laterally. You see, when you're laying on your side, you're usually tilt back a little bit, and your pelvis tilts towards your head. So your pelvis is not level. It's very hard to get it in a perfectly straight plane. And so what is not done is intraoperative x-ray. One, because the tables don't allow it, and number two, it's almost impossible to get a good AP pelvis with the patient, sort of on their side. So no x-ray is used. So if you want to judge implant placement or stability and leg lengths, it's really a guesswork. It's just experience. It's from looking at it with your eyes and how it feels. But you'll see with the anterior approach, we use a special table. The patient is supine. This is how you would get an AP pelvis normally. The patient supine facing up. So we can get a perfect AP pelvis and bring in the x-ray machine underneath the table as often as we want to check anything we want. So the implant position, the leg lengths, really anything. certain things we look for when we're preparing the hip and putting the implants in. One is the angle of the cup on the AP, what we call abduction. We want it to be generally between 30 and 50 degrees. Optimum would be 40, 45 degrees. The problem is if it's too vertical, the ball can pop out the top, all right? And if it's too horizontal, then as you abduct, the neck of the stem can hit the cup, it can impinge, and the ball will come out the bottom. So it's pretty important that the abduction is within that safe zone. The other thing we look at, it's a little harder to determine, is the anteversion. Now, here's a picture of the reamer. This is us sort of reaming out the cup. And as you can see, it's not a perfect profile of that reamer. You can actually see an opening, where the opening of the ball. That means that the reamer was not put in parallel to the floor, actually lifted it a little bit, so we're starting to see the opening of it. And that tells us that helps us determine our anteversion, or that the cups are facing forward. That's how your natural hip sockets are. Most hip sockets are anteverted about 20 degrees, and also by anteverting it, it keeps the ball from popping out the back. Okay, so just in summary, for the posterior approach, it does have advantages. It takes less time to do. Our high volume surgeons at Morristown, they can do these in about half an hour, 45 minutes. So you can get a lot done in a day. It's less OR time, and so you can do more surgeries. That's the advantage. Those are mainly the surgeon's advantage. The downside is that you cut muscles and tendons, and because of that, the hip is less stable. You have hip precautions. You have a higher risk of dislocation, and you have to wear a wedge afterwards. So we'll talk about the anterior approach now, okay? All right, so with the anterior approach, the patient, unlike the lateral position, is on their back. They're supine. The incision is not down the side of the thigh, as you see here, but it's actually anterior lateral on the thigh, and it's much smaller. I don't really advertise this as a minimal incision approach. I really don't care about the size of the incision. I find that if you try to make your incision small, you're stretching the skin, you're going to have wound problems, and your visualization is bad. So make the incision as big as it needs to be. It's usually about between 3 or 4 inches. And that's significantly smaller, just so happens to be a significantly smaller posterior approach incision. This is not a new procedure at all. This has been done since the 1940s, but it was done in France. So it's not in experimental stages, it's not developmental. We know exactly how to do it, and it's been proven. And I'll talk about some of the larger series that exist in the literature. So, one of the questions I'll answer later that's very frequently asked is, then why doesn't every surgeon do this? It's so great, and it's it's been around for so long. So as I explained before, we have to use a special table for it. Okay, it's called it's OSI is the company that makes it. It's a company that makes a lot of fracture tables. We have about maybe 5 or 6 OSI tables at Morristown, but this specific table is made for fixing pelvic and acetabular fractures. Okay, and in addition, we can use it to do these anterior hips. This was based, we go back in history, it's based on something called the Judet table. You guys ever heard of Judet X-ray views? It's a special type of X-ray view for the pelvis that we use to evaluate acetabular fractures. The guy who invented those, or came up with how to take those, also his father actually invented the Judet table. And this is just that was a prototype for this type of table. As you can see, what it does is it moves the leg, anywhere in space, and it can hold it there while you need to do what you have to do to prepare the hip for the hip replacement. So this is a true internervous and intermuscular plane. Not only are we working between in a natural plane between 2 muscles, each muscle is innervated by a different nerve. So there's no damage to the muscle, there's no damage to any nerve supplies to the muscle. And the muscles that you go between is the tensor fasciolatum muscle, which attaches to the iliotibial band, and the sartorius, which is one of the hip flexors that goes across the front of the thigh. And you'll see that this is not an accurate cross-section of the thigh, but people usually have a much bigger posterior thigh, really beefy usually. And the gluteus maximus is a big muscle. But what this is trying to show you is that this is a direct route into the hip, and it's the shortest route to the hip. There's usually not a lot of fat anteriorly. Even people who are overweight there's usually never more than 2 or 3 centimeters of adipose tissue. So you get to the muscle immediately. So it's easier to do this on people who are overweight compared to the back. The other thing is you're not working near any significant, vessels. A lot of people argue that people who try to bash the anterior approach say, oh, there's a risk to the femoral nerve, the femoral artery and vein. You'll see you're working well away from that. You know, there's a whole bundle of muscle that is between where you're working and where these structures are located. The implants are exactly the same. Whether we go through the front or from the back, we're using the same company, same type, same size, same everything. So there's no, people ask, do they last as long as posterior approaches? And they absolutely do, because the implants aren't different. It's the same technology. It's just the route that you're taking into the hip. So what are the advantages? Well, we don't cut any muscle or any tendons. So the patient should have less pain, they should have less weakness. And because of that, then people have quicker discharges when they're going to rehab. If they go to rehab, they're probably staying in rehab a little less, not as much time. People are returning to work quicker, and they're definitely walking with no cane, no walker a lot quicker too. And I'll show you some videos as we go along here. It has a very low dislocation rate. I'm supposed to update this slide because this is based on guys. There's this doctor in Southern California. We'll talk about him later. His name is Joel Mata. He's the guy who brought this over from France, and this data is based off of a paper of his that he put out years ago, which is only 500 patients. His most recent data is over 1,200 patients. And he's only had 3 dislocations out of 1,200 patients. So that's, what is that? That's 0.2%, basically. The literature points to 4% dislocation rates for posterior approach. That's a huge difference. And this is without any precautions. That's the other big difference too. So with an anterior approach, you can cross your legs, you can sit in a low chair, you can squat. There is no need for an abduction wedge. Because the patient is on their back, we can bring in this X-ray machine and we can judge for implant placement. You know, you can ask, Christos has been with me for the last 3 months, and he'll tell you that I take X-rays ad nauseum in there. Every time I put the reamer in, I take an X-ray to make sure I'm reaming in the correct position. Every time we put in an implant, we're making sure before we impact it that it's exactly where we want it to be. There's no guesswork. The other thing is we can judge for leg lengths. After the implant is in, you want the legs to be as close as possible to the other. You can be off on your leg lengths and still have a stable hip. So when people are on their side and people are doing the traditional posterior approach, your leg lengths can be off, but you can still be kind of stable. You can move it around and it won't pop out. You won't know until the patient's in the recovery room and an X-ray is taken whether the leg lengths are equal or not. We can take this image in the operating room while the trial is in, never mind the actual implant, but the trial, and we can measure leg lengths, and if we don't like it, we change the modular components until the leg lengths are as close as they're going to be. So this is us in the operating room, and you see the patient is supine. You can't really tell, but this is basically the feet are here, the head is up here, and here's the anterior lateral thigh. I was trying to show you before is the patient is in these traction boots that are attached to these spars, and that's the spars that bring your leg up around and will lock you in any position you want. But you see the boots come out of the spar. So under sterile conditions, we can grab the boot out of the spar, and I can also range you. And I take you through a whole range of motion. We go all the way up in flexion, internally rotated, adduct. That's how it pops out the back. And we'll also range you in extension. I'll bring you all the way down and externally rotate you to see if you come out the front. And it should, it almost never does. If it does, we usually have to change the leg lengths. But after we're happy with the stability, then we go and we look at the leg lengths on X-ray, and we'll say, oh, the leg lengths are good too. So we know, there's 2 ways to determine that the hip is stable. So these are just some cases. This is a 72-year-old man. He actually had left hip arthritis, but his right hip had been replaced about 1.5 years prior to this, the traditional way. He wasn't happy with how quickly he got back to things. He's a very active guy. He'd heard about the anterior hip, and he wanted to have it done. So the day of, we got him out of bed. This is him here. This is 4 hours later.
Wow. Oh my God.
Chris is the
No need
cameraman
for
on this one.
rehab.
Wow.
So he had his left side done. So you'll see, I asked him to do one-legged stances on both sides. So say he'll put all the weight on the non-operative side, lifting his operated leg, and then he'll do it on the, then he'll put all his weight on the operative side, I think.
He's going pretty far too.
We go, we walk everyone the same day of the surgery. The therapists do it, but then we go by at the end of the day and do it ourselves as well.
No pain?
And,
Oh my God.
look at that.
Is he running a marathon now?
Okay, so you laugh, but this guy owns his own business, okay? So he's his own boss, doesn't have this, but so he goes back to work 4 days later. I'm sure he was doing heavy labor, mostly desk stuff, checking up on things.
How long will it take to take the staples out?
2 weeks. He had already played golf before we took his staples out, on a car. So this is him. He went home 2 days later. Okay, so he's walking with just a cane the day after, and then he went home on the second day. The fourth day he went back to work, and on the fifth day he followed up for a wound check. This is him on the fifth day.
So he was walking even before the staples were taken out?
Oh yeah.
Playing golf.
Where is this?
So look at this. This is 5 days later, no walker, no cane.
Oh my.
It's the bionic man.
Isn't it so off?
No, so is it definite that the staples is usually taken off at 10 days or 14 days?
The staples?
Yes.
Well, I wait at least 2 weeks, so 14 days, but if it doesn't look ready, then we leave them in a little longer. I would err on leaving them in longer. There's no downside to it.
Staples.
Here's another woman. This is a woman, a 66-year-old female. She had hip arthritis, never had a previous one done. And just as a side note on that guy, I just saw him back recently. He's 6 weeks out at this point, playing 9 holes, not with a cart. He's just left for Florida on vacation. He thinks that this probably saved him about 6 weeks, is what he told me. He thinks that he's 6 weeks ahead of his previous hip replacement. So the long-term outcomes, I'll be honest with you, are the same. If you look at someone 5, 10, 6 years down the road, they're both doing well. But the posterior patient has hip precautions, the anterior patient does not, and the recovery is quicker with anterior. You're back to your stuff quicker.
Question, does he go to therapy occasionally just to make sure he's doing the right,
Well, yeah, I asked the patient if they want to go to therapy or not. This gentleman is very motivated, very active. He worked out up to the day of his surgery, so he didn't need to go to therapy. We have patients that go to outpatient therapy. They're not going to need it as long, and they don't have to have hip precautions reinforced or anything like that.
Have you noticed a difference in the healing of the surgical site on the posterior versus anterior?
Well, the incision is usually smaller, so if there's less time to heal, so there's less tensile strength or the tensile forces pulling the wound apart. The thing is, though, the thing with this incision, and this is another downside to the anterior approach, is it's right here. It's right on the belt line in front. And it's right, people are overweight, actually anyone, they have a little flap of tissue, unless you're like,
It's infected.
I'm sorry?
It can get infected easier?
Well, you have to be, not infected, but you can have some wound breakdown. It can, if you shower and you don't put a piece of gauze in there, it can kind of get damp, macerated, so you have to keep an eye on it.
So this isn't good for patients whose cognition is not all that good? Like
Well-
dementia, Alzheimer's?
No, actually, it is. It is for them because you have to worry about hip precautions.
Exactly.
Any hip fracture that comes in on my watch when I'm on call gets an anterior hip. I don't do hemiarthroplasties, and especially if they're demented, because how are they going to follow hip precautions? With this, you don't have to worry about it.
Right.
You just have to be, family member just has to take a look at the incision from time to time, and that's just for the first week. That's all.
I went to dementia patients, we don't want to move their feet for any length of time either.
Right. All right, so this is another case, 66-year-old woman. And so the same day of the surgery, we walked her. She walked about 300 feet. I don't think we have in the hospital footage, so you have to take my word for it. She walked that night, just as well as the other guy. She went home on the second day, and this is her 5-day follow-up.
Wow.
See?
So again, I asked her to do one-legged stances. We'll see if she.
Doing a runway.
Yeah, really?
You see?
Wow. And that's on the surgical. Oh.
People ask when they come back to follow up, they want to see their videos, and they're like, I was limping at 5 days. I'm like, you have no idea. Most people are still on walkers.
So all the surgeries that go from the anterior are all weight bearing is tolerated? Also,
Yes,
correct?
well, I do that with any approach, but yeah, they are weight bearing is tolerated. And this woman, she does some type of desk work also. I don't remember if she works in a bank or some type of desk work. And she was back to work in 2 weeks, so that was pretty good. Okay, so the main question I get all the time is, if it's so great, you know, it's been around for so long, is why doesn't everyone do it? Why don't all joint surgeons do this? And there's a couple reasons. You know, and we got to go back to history to really understand why. So this approach, also called the Smith-Peterson approach, has been used since the 1800s. But it's been used for other type of orthopedic procedures, for pediatric surgeries, surgeries for hip fractures. That's why trauma surgeons, and I was trained in trauma, that's why we're very familiar with this approach. It was used for a hip replacement for the first time in 1947 by this guy, Robert Judet. Okay, and he was a very big trauma guy in France. He had used this approach to fix hips, and he was like, this is a great approach. It's right into the hip, it's internervous, it's intermuscular, and he developed a way to do a total hip through that approach. Him and his student, Emile Letournel, and by the way, these guys are probably the most, two of the most famous pelvic and acetabular surgeons. These guys are the fathers of pelvic fractures. It's like, they're like our Michael Jordan. These are the guys who were doing hip replacements through an anterior approach in France for decades. And it wasn't until the trauma surgeon from Southern California, Joel Mata, went out and visited Judet in the late 80s. Basically, he wanted to go out there to learn how to fix acetabulums and pelvic fractures. And he saw them doing these hip replacements through an anterior approach. And he's like, what's this? Why are you doing it this way? And they're like, oh, it's great. You know, there's no precautions. They do well. And he saw it, and he wanted to do it in the United States. And everyone in the United States was like, Joel, you're nuts. Don't listen to these Frenchmen. They don't know what you're talking about. And so he actually didn't do one until 1996, when there was someone who had one done in France and wanted another one done. They asked him to do it, and he said, okay, I'll try it. And he saw the results, and he started doing them little by little. And now he's the authority. He's the living authority on the anterior approach. He's done almost 1,500 of them. So Joel Mata knew how to do it. He taught his students, their students taught their students, and so on and so forth. So more and more people started doing this. You know, that's me. I learned from one of his students. And now Christoph's knows. So, you know, as time goes on, more people will start doing it. More people in the population will have anterior hips. I know it'll grow in popularity. It'll probably be the standard way to do it in a couple decades. So that's the number one reason. Most people don't know how to do it. That's why. The other reason is it takes too long. Okay, for some surgeons, it takes on average about it takes average about 2 hours. Joel Mata does it in about 1.5 hours is his study average. As I told you, a lot of people in Morristown can do hips in about half an hour. So they're flipping rooms, they're doing 12 in a day, and that's how they make their money. And if we ask them to now go from a half hour a hip to 2.5 hours a hip, they're not doing as many joints. They just financially, it's not feasible for them. So that's another reason why. And the third reason is a lot of places don't have the proper table. That table is pretty expensive. You know, it's about $200,000. You know, we have it in Morristown because it's a level 1 trauma center. We need that table to fix pelvis and acetabular fractures. So it's it's a luxury for us. A lot of places don't have this, and a lot of surgeons they will try to do this without a table, but it's not as good. It's not as effective. You'll see on this table, there's plenty of room underneath to bring in the X-ray and to see what you're doing, make sure everything is perfect. You know, this is us in the operating. This is us putting in the cup under fluoro scan imaging. Here's the X-ray tube comes in. We take a shot. We know exactly it's in the right position before we impact it. When we take the impactor out, we look at it. It's where we want it to be. If not, we change it. So we can judge for implant position as well as, this is an intraoperative photo of a guy with a previous total hip. This is the hip we're putting in with a trial head. That's why you don't see the head, it's made of plastic. And this is us, we measure the leg lengths and make sure that they are as perfect as they can be. If you do it without a table, the patient is supine and the pelvis is flat, but you see the base of the table is in the way. So if you were to bring in the x-ray tube, you'd be hitting the table. You can't visualize anything. So you're going based on feel, not using the advantage of x-ray. All right, so what are the post-op rehab implications of the anterior hip? Well, as you asked before, the weight bearing is tolerated. Okay, they have no hip precautions. The patients don't even have anterior hip precautions. They don't have to wear an abduction wedge when sitting or when laying down. We get them out of bed on the same day if possible. Sometimes they have blood pressure issues, if they're hypertensive or feeling lightheaded, and we'll wait for the next day. But 95% of the people we get out that night. And then it's not unusual to see patients going directly home if they were going to go to rehab with a posterior approach. And also they take less time to kick the cane with the walker. So much enhanced recovery. Yes?
Are there circumstances under which some orthopedic surgeons would apply hip precautions for this? Because I've had a number of them that had hip precautions. Are there special circumstances under which they would?
The only one I can think of is if you implant the hip and intraoperatively you're arranging them, and at the extreme arranging, it pops out the front. If you don't feel like revising the cup, then you have to give them anterior hip precautions. But if that happened, we haven't had that happen to us, but if that were to happen, what I would do is just, you dislocate the hip that's in there and reposition the cup, that's all. You can reposition the cup or reposition some of the implants that we use, you can change the version of the neck on the femur, so you don't have to move the cup, you can just make the cup the neck angle more retrovert, so that it's less likely to come out the front. So there's ways, if you leave the OR and you range the hip and it's not popping out, because you see what we do, we pretty much extend it as far as it'll go. If it's stable with the wound closed and with the wound open and the capsule open, there's no reason to give them precautions.
Maybe they didn't have the table.
Maybe they didn't have a table. Like that guy. Yes?
I've had patients who they say posterior precautions, they want to avoid extension.
Yes,
Could you repeat the question? I'm sorry. Oh, well, with posterior approaches, they have...
posterior precautions, like, so they don't want too much extension on
It's
their...
anterior approach.
No, posterior approach.
Oh,
Yeah, I think that the surgeon's probably just being
No,
extra
anterior,
cautious.
sorry,
An anterior approach.
anterior approach.
Yeah, so anterior hip precautions are basically the opposite of the posterior precautions.
Yes.
It's extension and external rotation. So if you wanted to be extra cautious, you could give people those precautions. But my point is, in the operating room with the capsule open, so even before we close the capsule for further restraint, we're ranging them. We extend them as far as they can go. I mean, you saw that picture, right, where we drop the leg and I'm externally rotating it. And my assistant Christos is in there, and he's making sure the ball isn't even, the neck isn't even impinging, and we make sure that there's no danger of it coming out. And at that point, we know they're not going to do anything or wait. That if patients fall or they have trauma, that you can't avoid. But as far as motions go, there's no motion precautions.
Are there patients for whom this is not indicated, or it's different from the...
Right, good question. I get that a lot. You can do this for any primary hip replacement for arthritis. Anyone who would get it, who's a candidate for a posterior approach, is a candidate for an anterior approach. If anything, it's easier on patients who are overweight. The only times I can think of that you would want to go through the back is if someone has had a previous trauma and has had plates put on the back of the pelvis, because you might have to take some of the screws out in order to put the cup in, and the plates are put in from the back, so you have to approach it from the back. That's what I can think of. And even then, you could cut the screws from inside the socket if you wanted to definitely have an anterior approach. So 99% of patients can have this thing. I saw a news, internet, there's a news article on an internet site, and the doctor being interviewed, he's from the Midwest, he was saying that elderly people are not a candidate because their bones aren't as strong, they're not as dense as younger patients, but that's totally false. I mean, you're not doing anything different than you would through the back. If anything, it's easier for recovery. Elderly patients wouldn't have to worry about precautions or anything. Okay, so this is, I apologize, I should have updated this, but this is the older publication by Joel Mata. And this was a series of over 500 patients. And you see it took about an hour and a half to do, and he had 3 dislocations, so that's 0.5%, just over 0.5%. That's compared to the Medicare database says 4% for posterior approaches. So that's huge numbers, that's a pretty accurate percentage. He never had another dislocation after this, so he's now up to about 1,300 hips, and he still has only had 3. So now it is about 0.2%, so that's extremely low. His mean hospital stay was 4 days, but he had a couple outliers. People were most likely to stay 3 days. That was his mode. Okay, and then people most likely were walking with no assistive devices at for the first time at 8 weeks, and 8 days, and they totally kicked any walker or cane at about 2 weeks. Okay. All right. Here's another case. This is, I show you some extremes, people who were relatively younger and in good shape. This is the other extreme. This is an 88-year-old guy, okay? He had a hip replacement done on his other hip 3 years before, and it was a posterior approach. He didn't like his he liked his ultimate outcome, but didn't like his recovery. He was in a nursing home for 3 weeks. He says he didn't do much out of bed for the first 10 days, because of pain, because of weakness. He also didn't like the precautions. So he came to us and we did an anterior hip, and this is him 4 hours after the surgery. So I asked him to flex his hip, and at first he's cautious. He's like, am I allowed to do that? I'm like, yeah, go ahead, flex it as much as you want. So you'll see, this is 4 hours afterwards. All of his muscles are intact. None of them have been cut, and he can do that.
That's the hip you operated on?
Yeah. And then he asked, can I go further? And I say, oh yeah, go as far as you want. Now, this next video, and who here is a therapist? Or even a nurse for that matter. Don't get mad about how I'm getting him out of bed. Okay? I am not following total precaution.
Yes, you are not.
See, that would be a no-no normally, but here it doesn't matter. You can see he's definitely flexed past 90 at the hip, right? This would be a no-no. Okay, so this is the rest of that. I'm going to have to censor some of this video. We see a little skin here, so.
I'm not the defendant.
We're not used to
We're
that.
all in the medical field.
There we go. We'll, censor that. There we go. No, so there we go. All right, so I asked him to go ahead and take a couple steps, and this guy is off to the races. Look, I had to actually ask him to slow down.
Was it less than 8 hours or?
This was 4 hours after surgery ended.
Did he have pain medication before
He had a spinal, couldn't.
Oh,
He actually, I'll be totally honest with you, he was sore the next day because he refused all pain medication the night up. So then we gave him some Percocet the next day, he was fine. But spinals are very effective for pain control. They
I want one of those. I need it. If and when I.
So this is not bad for an 88-year-old 4 hours afterwards.
Wow.
So this was the left hip again, the side the drain is on. So we asked him to do some leg stances here. Now he's leaning on the walker, so he's cheating, but still he still is not afraid to put all his weight on the operative side.
It might be expensive.
And there he is now, putting it all on the operative
And
side.
great pressure, oh my gosh, wait there.
All right, so this gentleman, he did stairs with a cane on the second day, or I'm sorry, 2 days after the surgery, and then he went home on Percocet, did not go to a nursing home like he had 3 years previously. So you can see this is only a case. We need a study comparing anterior to posterior to really prove it scientifically. But now, these are 2 cases now that people are saying there's a huge difference in my recovery between an anterior and posterior, because the luxury of having both sides done differently. This is him 5 days